The Royal Commission, headed by Justice Horace Creever, and it was established by the Canadian government in October of 1993. And there were many recommendations in the Creever inquiry, some of which I'm showing on this slide here. There were, of the 50 recommendations, 25 of the recommendations applied directly to the blood operator, to both Health Canada, or not Health Canada, Canadian Blood Services and Héma-Québec. Why has the policy been maintained? So in terms of Canadian Blood Services, we've always been open to change, to changing this policy. Our approach has always been one that's tied to the safety of the blood supply for patients, for recipients of blood and blood products, and finding that right balance and the evidence to support the change that would not introduce any new risk or any significant risk for the recipients who bear all of the risk in the blood supply. Just quickly looking at some of the statistics, one of the key factors that makes Health Canada maintain this deferral policy is the window period, so the time frame in which someone becomes infected with HIV and the time at which our tests that are in place now are able to detect that virus. So during that 10-day period, if someone had just, or maybe it's 12 days, 10 days, during that window period, if I were just infected today and I went to give blood tomorrow, then all of the recipients of my blood would then also become infected with HIV, but we would not know that because of the technology and the testing measures that are in place right now. In terms of risk modeling, Héma-Québec and Canadian Blood Services work together to present our submission to Health Canada to request the change from the lifetime deferral to the 5-year deferral, and a huge part of Canadian Blood Services' role in that submission was around stakeholder engagement, and I'm going to speak more about that, as will Jennifer and David. Part of the responsibility that Héma-Québec took on in preparing this submission was doing some risk modeling to take a look at what risk might be in place, what might we be exposed to. And for a 5-year deferral, the incremental risk is less than 1 HIV-infected unit of blood entering the blood supply in every 1,000 years. So we know that was obviously very compelling evidence to present to Health Canada. On a purely scientific level, we know that a 1-year deferral would probably equally protect from risk, but we have to move through this in sort of baby steps, if you will, in order to be able to be granted the right to be able to change the policy. The role of public participation played a key was very key in getting to Health Canada and have them agree to changing the deferral. Any change that's made, not just about this policy, but any of our regulated policies must be approved by Health Canada before they're able to be implemented. The other factor to keep in mind is that there's no, at this point, there's no international consensus on what an actual safe deferral period is for maintaining the blood supply. Scientific evidence was definitely a key component in our submission, but one of the main things that Health Canada looked at as well was stakeholder support. So in terms of how we do our business, not just about this particular policy, but in general, anything that we're doing, we involve anyone who can be affected by the policy or the project or whatever it is that we're working on, and the input coming in would be from anyone who has anything to contribute, anyone who has an interest, or anyone who can affect our ability to actually carry out the change. So in 2011, our board of directors, given all of the information that we gathered, given the the changes in technology and what was available to us, the board directed us as an organization to change the existing indefinite deferral to one of a defined period of somewhere between no less than 5 years, no more than 10 years. And that was to be determined through extensive consultation with stakeholder groups. We also created a research paper, and that was reviewed by an international panel of experts in various disciplines, from public health, gay men's health, epidemiology, risk assessment, ethics, and HEMA Quebec was also part of this. And I can tell you that going into the consultation process, the stakeholders that represented the LGBTQ community were very firmly entrenched in the 5-year end of the spectrum, angry but entrenched in the 5-year end of the spectrum, saying if that's the best we can do right now, we'll support that, but more to come. And the patient groups were, for the most part, very entrenched in the 10-year based on the fear that they were potentially going to be exposed again to tainted blood supply. So who did we look at in terms of getting this consultation process going? We wanted to really fairly represent, as I said, those who are affected by or those who are interested in. And so we looked at national organizations, regional, local. There was previously an LGBTQ working group set up within Canadian Blood Services that was made up of external folks. And there were some individuals who just sort of raised their hand at our board meetings, at public board meetings, or through email or other correspondence saying that they were interested in this and they really wanted to work with us to help affect some change. We also ensured that we had an equal number of voices representing all of the different perspectives, so we wouldn't have 10 patient groups and one LGBTQ representative. That just wouldn't have been a fair balance. So the goals of engagement, as we began pulling all of these folks into the room, were, of course, obviously wanting to increase acceptance of any kind of decision that was made going forward. We wanted to be able to gather the insights and input from these people, because every single person who was involved in this, all of the players within Canadian Blood Services, the players within the patient community, blood recipient community, the players within the LGBTQ community, nobody knew what they didn't really know about the other perspectives that were potentially coming into the room. So this was an opportunity for us to increase some mutual understanding, increase some support, and create a platform where trust could be developed between all of the different persons representing the different perspectives in the room. And we did that in a very transparent manner, so that there was always an option and an opportunity to speak to anything that was being raised. So in terms of the end results of our project, we ended up, from a relationship perspective, we watched barriers slowly disintegrate. As I said, the two different perspectives were very entrenched coming into the beginning, and over time, listening and talking and sharing experiences with each other, some common ground was found. Fear emerged as a common theme on from both perspectives. Fear from the patient group, as I said, of again being faced with the possibility of a tainted blood scandal repeat, and in the LGBTQ community, fear of discrimination, fear of institutionalized homophobia, fear of whatever was already being experienced being sort of magnified within this particular policy in our organization. So at the end of the process, there were, and I'm not going to go through how and all the steps, but at the end of the process, we ended up with a commitment for ongoing collaboration from all the parties that were involved. Letters of support were written to the Minister of Health from all of the parties, again, all of the different groups that were involved, and that carried a lot of weight. The Minister of Health, obviously there was some politics in looking at making this particular change to this policy, but I think Health Canada would have been very slow to react, and maybe not even react positively had we not been able to show support official support, in the form of a letter from each of those organizations asking to make the change and saying that they were behind it. From a scientific perspective, again, the modeling, the risk modeling supports a move to a 5-year deferral at this point. We know that incremental change will lead to an even shorter period and perhaps other ways and means of screening, but we had to have that. We had to get our foot in the door. We had to open the door with Health Canada. This was a way to do it. We also had to do it in such a way that those who bear all of the risk, the patient groups, were behind this change as well. If they had said no, that probably would have put an end to this last round. And we've been doing this dance for many, many years, decades now, trying to get a change to this policy. But we finally got to a point where we had this consensus and strong evidence to present to Health Canada in order to support the change. So that's sort of the background in terms of how we got to where we are today. There's a lot more information. I'm happy to share that at any point. Instead of asking questions along the way, I think we'll just run through each of the different focuses for our presentation, and then we'll be happy to take some questions at the end. So now I'm going to pass it over to Dr. Fearon.